Welcome back to the Core EM podcast. Core content for anyone, anywhere, and just in time. This is the official podcast of the NYU Bellevue EM residency program. So this is an additional podcast for the week, and it's going to showcase one of our Grand Rounds talks. This one's from Jeremy Faust, and it was entitled Music in Emergency Medicine. Now, I think everybody knows Jeremy from the Foamcast podcast, and Jeremy is an absolutely brilliant speaker. This is a very unique topic, so we decided to publish it in the full length. It's about 40 minutes long. A couple of things to point out with this talk. There were some areas where Jeremy played some video with no audio, and we cut those out. There was also a section where he played an excerpt from a movie from Sony Pictures, which we had to cut out as well. So there might be some choppiness in there, but I think the overarching messages that Jeremy has are really critically important for emergency physicians to know. So with no further ado, here's Jeremy Faust, Music in Emergency Medicine.
Swami, thanks so much. It's awesome to be here. Christy, it's good to see you. It's been a few minutes. I asked Ruben Strayer, what's the difference between Sinai and Bellevue? He said it's pretty much the same, except the Bellevue residents work much harder than you. So, it's like, okay, I don't know what to do with that. It's like, no, you work pretty hard, but they're just better. Okay, all right. And then I started talking like him, because you can't help it. You're like, okay, all right. It's very infectious. So this is Music in Emergency Medicine, how we can change our training and our practice. And I'm going to just tell you how I got to this talk. So when I was 20 years old, I was doing a summer research at UCSF, and I'm just in the library. And I was a piano player and a singer, and I wrote some music. I was a music major, pre-med. And there's this article about how the human voice works. And it's written by a guy who's an MD, and who's also a doctor of musical arts. And conductor and he sings, and I thought that's going to be me. So my whole kind of life was kind of directed towards, I guess, this moment maybe. So if it doesn't go well, I'll be crying. But I did try to keep this balance going, and I did a lot of music during med school and even during residency, and it definitely kept me kind of going. But people always say, oh, what do you sing to your patients? And I find that that's a bad idea when they want opiates. So that's not what this talk is really about. But this talk does kind of marry a few things, which is my love for music, my love for emergency medicine, which is, I think, something that people know that I have. And then kind of this audience, a progressive audience that sort of looks for different ways of thinking about things. So this is kind of exciting for me. So let's see how it goes. So you should listen to Foamcast, because Lauren left her as my co-host, and she has a great drawl. And I asked Twitter about music, and they said, well, music is good in terms of music and medicine, because it kind of opens up a soft side, and there's some technical skills you develop as a musician, maybe. It helps with the attention to focus and detail and humanism. And musicians are trained to listen, and so doctors should be too. And I don't think we're trained to listen all that well. We'll get into that a little bit. So this is a three-part talk. The first is performance, the second is sort of pedagogy and how we learn, and the last is about sort of how we can put some musical things into practice without our patients trying to stab us, which is always a good combination as well. So let's just start with first impression. There's a great paper in this music journal, When First Impression Counts. It's called Music Performance, Audience, and the Evaluation of Stage Entrance Behavior. Like how you walk on stage has been studied. And so what they did was, they went to the top competitions in the world, violin, piano competitions, and they basically just showed people in the survey videos of people walking on stage. And they asked them to write what's good, what's not, and they came down to 6 things that kind of matter for good entrance. Nodding, direction of gaze, so you don't want to be looking straight at the ground. Don't touch yourself. Which, if there's a more generalizable finding in literature, I don't know what is. Your stance width, your posture, your step size. This is really nitty-gritty. And how resolute you look. Now, think about this. Every day we make an entrance. What is emergency medicine? But every single day we make a first impression. We make first impressions for a living. And so we should learn from what these musicians are doing. So they actually looked at 2 ideas. The people on the left were the ones who said, you know what, after that entrance, stop. I do not want to hear what this person has to say musically. So just imagine, you walk in, and they're like, I have no interest in what you have to say musically because of your entrance. And I don't think that we're too far from that. I think we've all come to the bedside and met a patient who's like, nope. Or we've met a patient who's like, oh, you look like someone who cares. And so here are the 20-some-odd% of people who said, stop. And what the green and the blue on the right, these are people who said, oh, this is kind of an acceptable entrance or an inappropriate entrance. Stop, so we don't care. For the people who said, you know what, I want to hear about this, I want to hear music from this person, they all made appropriate or acceptable entrances almost to a key. So what can we learn about this, right? Well, here's the first correlation. Predictors of parent satisfaction in pediatric lac repair has to do with how you look, how you present yourself, your confidence. It has very little to do with your stitching technique, actually. So I'm going to read for the last time. Provider performance, communication, caring attitude, confidence, and hygiene is the strongest predictor of excellent parent satisfaction for peds patients in the ED visits for lac repairs. So basically, it's just your decorum, it's not your one-handed ties, which bothers me because I practiced. But you have to know this. So this is Yo-Yo Ma, and he is certainly one of the best cellists in the world. But he is definitely the most famous cellist in the world. And the reason is this picture. When he walks into a room, he is just oozing enthusiasm and excitement for what he's about to do. And he does it when he plays, and it's so infectious to watch. So we gotta be a little more like him. So the next thing is really about listening. And how do we listen? It seems kind of obvious. We know hearing is one thing and listening is another. We've heard this sort of thing. What skills do we use when we listen? What skills do we not use? I mean, we certainly are hearing. Are we tasting when we listen? And I would actually argue we smell when we listen. If a patient says to me, I don't smoke, and they smell like smoke, I'm like, yeah, I hear you. You smoke. Right? So listening is a very multifaceted thing. And which is more important, sound or visual, or other input? And so when we ask professional musicians this question, what's more important when you're judging a music competition? Sound or like appearance? 96% of the music pros said, oh, it's the sound. Come on, it's the sound. I mean, we're musicians, folks, right? So let's find out if that's true. Great paper from the students of National Academy of Sciences. So which would you want? Let's say you're a judge of a music competition. Here's the design. I'm going to show you clips of 3 finalists in this competition. Okay? And you get to choose audio clips only to judge the winner. And by the way, these are like 6-second clips. This is like snap judgment. You want video clips, silent video. You're going to judge the competition on silent video, watching them. A mime could do this. A mime could literally do this. Or do you want the maximum information, audio and visual clips? So let's try it. This is where I really hope the sound works. So here, actually, if you have like a pen or an iPhone or a memory at all, try to think of which of the next 3 clips do you think is the winner. Video only. So, same players, video only. All right, now just to really confuse you, here's audio and video together. See if your vote changes. Just pull yourself, like who's in the lead so far? Will this change anything? Results. So they looked at amateurs and they looked at professionals, and they asked, "Can you do this?" And first of all, good news: the amateurs and the pros performed the same at choosing who won. So the pros were like, "Oh, I guess we didn't know so much." So when you ask amateurs, which is more important, sound or video, just a binary question. Even the amateurs were like, "Yeah, sound's more important." Of course, 96 of the pros said that it was more important. Now, looking at actually who selected the actual winner, these are amateurs, so it should be 50-50, right? Or no, this was actually, so these are 2 different experiments. So the first one's sound, so very few did it, right? I mean, the sound alone is like way less than a chance, so very confused. Video only, 53%. And with the audio and video together, it's about average, just chance. So video is actually best for amateurs. Figuring out who's going to win this thing, okay? So, but what about the pros? So sound only. Remember, they said 96% of the pros said they would choose on sound alone, right? So they were like, 33% would be chance, right? So actually, the sound screwed them up. More information on the right actually hurt them. So it turns out, when we listen, our eyes are actually doing a lot of the work. So here's an interesting thing. When they went and they asked people in the survey, okay, forget all that, forget this. We're going to show you clips. And just tell us who's the most passionate. And when they were asked to identify who's the most passionate, they correctly got the winner 60% of the time. So the best indicator for people looking for passion. So that's some sort of marker for what the judges thought would win, right? So totally confusing information about how we listen, right? So let's do it again, judging for passion only. So, by the way, I lied to you. The name of the study is called Sight over Sound in the Production of Music Performance. I didn't want to give it away. So actually, it's great. They did a ton of other experiments. It's actually a really fascinating paper. All right, so how can we apply this? We can use this when we're speaking to our patients, right? I mean, we don't just listen, we look. And a lot of things that you don't even realize you do. So, for example, if someone comes in and they have, like, crushing chest pain, and their spouse is, like, sitting there like, man. You look at the spouse and you're like, in your mind, you're like, why am I not scared about this guy? And it's because the spouse has been there. They've been there before. It's like, yeah, this is just like part of the course. Don't even worry about it. And so the information we're getting is so global, but we need to be aware of that so we can make better judgments. So we can actually do this. Performance is persuasion, right? When you walk in or how you kind of present yourself. We already saw how that makes a difference. Listening is multisensory, and we really underappreciate visual information. Okay, so that's part one. So part two is pedagogy, preparation, and practice. So how can we sort of learn from musicians to get better at what we do? And so there's kind of, these following quotations are three approaches to practicing. Okay? The first one you're familiar with. See one, do one, teach one. That's what we do. We're very proud of this. Oh yeah, medicine, we're hardcore. See one, do one, teach one. Yeah. Amateurs practice until they get it right. Professionals practice until they can't get it wrong. Well, suddenly see one, do one seems pretty lame. If I don't practice for 1 day, I know it. If I don't practice for 2 days, my critics know it. If I miss 3 days, the audience knows it. This is one of the greatest pianists of the last century. So which one are we doing? Okay, so here's a study that's perfect for this talk. Music lessons, revealing medicine's learning culture through comparison with that of music. Thank you, Watling et al. Like, okay, that's great to have this paper. And they asked med students, residents, and music students what matters in pedagogy to them, and the differences are pretty striking. Okay, so pedagogical approach. Med students, learn by doing. Get in there, do it. Music students, learn by lesson. They want to be training and being taught and being working on it all the time. They would never go to Carnegie Hall without practicing A-Duets. Performance goals, competence. I mean, even the word core competency. I mean, that's just almost insulting, right? Core competency. How about core excellence? How about saving our patients' lives because we know what the hell we're doing? Even better. Music students know that if I'm not better than the next guy, I'm not getting solo. I'm not going to get the job. I'm going to be not doing music for a living, which is not why they went to Juilliard. How about ideal teacher? What kind of teacher do medical students want versus music students? Well, medical students want the clinical master. They don't care about pedagogy. Oh, I studied with so-and-so, some big person, big name, debate. Oh yeah, I work with debate. I don't know, is he a good teacher? He's famous, he's got some device to debate. Music students, teaching more important than performance. If you go to Juilliard, they have a bunch of really famous piano teachers. Now these people were actually fairly successful musicians in their time, but they are famous teachers. And occasionally someone comes in and they give like a one-off master class from some famous person. But the Juilliard students want someone who's going to teach them how to play in a healthy manner because they've got to do it 6 to 8 hours a day. They don't care what the current great pianist may know accents. They want someone who says, look, the way you're holding your elbows is going to kill you in 5 years, so let's not do that. So music students care about teaching performance, not fame with the teacher. And then feedback. We think that self-assessment is possible. Oh yeah, I know what I'm doing. Feedback is just this thing that I have to deal with. And when I get really good, I won't even need it at all because I'll be good. Music students, external review is essential. Great article from the New Yorker a few years ago, about Local One Day. Personal best, top athletes and singers have coaches, should you? And I love the anecdote. Smart guy. He noticed that people like Renee Fleming, one of the most famous opera singers in the world, she goes to her coach still to this day. When she has a new piece, she works it up with the coach. Go to the Olympics and watch the world record breakers. Usain Bolt has a coach. His coach is not better than he is, right? His coach is worse, right? But if the coach was better, he'd be doing it, right? But he would never go without a coach. And so what Gawande did was, 10 years into being an attending, he invited one of his old mentors into the OR and said, watch me, what am I doing wrong? What can I do differently? And what he found out was a couple of things. One, he's like, okay, the way you're standing during 95% of your time is blocking the view of your residents. So they can't see what you're doing. If you just move this way, you're going to be a better teacher. Does it bother you to move that way? He's like, no. It's like, well, then just change it. Okay. That was it. 10 years of wasted, done, fixed. And he also noticed a few technical things. Look, the way you're moving this way, just a few fixes. So the idea of us having a coach or a consultant. Now, we're a little bit lucky, right? Because as we start our careers and start getting attending, a lot of times you can go down and say, hey, I got a question. You can talk to someone more experienced. So we kind of actually have an opportunity to insight you, kind of get those consults and get that feedback kind of in real time. So we should be doing this as well. It's a great idea. Okay, so then let's talk about a different pedagogical thing, which is stress inoculation. Big topic, right? Stress inoculation. You got to be tough. You got to be good. You got to be ready. You can't get scared. You got to do it. Go. A. We're prepared, but we're just nervous. That's what it is. The reason I'm scared to do that crank is that I really know what I'm doing, but I'm really just nervous. I don't think so. We're unprepared and we know it. So stress is your body correctly diagnosing your incompetence. Right? And now if you've done 100 cranks and you're nervous and you're having trouble, fine, go to see a performance psychologist. I think that's going to happen in about 2 to 5% of us. But the rest of us, until we've done 100, and it can even be 100 on mannequins. I have the tubing at home that I do while I'm watching television. Until we've done 100 of these, we're not stressed out. We're just incompetent. And the musicians are onto this. They would never do this, right? They will always go to performance ready to go. Okay. So where's the tough love, right? Why aren't we getting trained this way? We're getting baby. So we need to change how we learn or change how we teach in the future when it's our turn. Okay. Musicians do this. I'm going to see if I can just turn this up a little bit. So how do musicians get to this level? And I wanted to know. So I asked a friend of mine to learn a piece of music for me. So I asked him, have you played this piece before? It's the Sonata by Carl Vine. This piece is so hard that they basically banned it at a lot of competitions because everyone's doing it. It's like, okay, yeah, you can play the violin, but this is the top level anyway, so no more. And if anyone who does music, this is the first page of the score, and it's fast and it's nonstop. So we're going to watch my friend Steve learn this piece in 3 clips. So I gave him a camera, or I filmed him the first day, and I left my camera at his house and just said, turn it on when you practice, and just show me how you kind of get into this thing. So I got 3 like 1-minute clips, and we'll sort of see. It's hopefully like not watching paint dry. It's like you'll sort of get into like what he's getting into. You tell me how that works.
All right, that sounds fun. Okay. Normally, sort of play through this long stretch. Is that all right?
This is sight reading, by the way, which is sick. Little trouble here. Identified some areas where he's going to have to get into it, okay? So this is Steve. Don't feel bad. The New York Times thinks he's good, and so does the New Yorker. So. It's not some guy that I got in the subway. When I used to say I was a pianist, now I said I play the piano sometimes. All right, so here's day 2. He gets the metronome out. About a minute here. So here's a little more when you start really getting into slowness. 30 seconds. So being able to use the score a little less. That part must really suck. And then here's day 3. And this, I think this is like a minute as well. Last one. I really don't. And I've started to do this, and even I'm not doing it because no one's telling me to do this. I don't have this teacher in Whiplash yelling at me. Training conditions, right? I mean, he plays it fast, he plays it slow. Derek Jeter, all these guys, they put the weight on the bat, right? So that when they take it off, it feels good. That's how we should do with our procedures. Swimmers, they use these drag suits, and then they take them off, and then they feel like they're just flying. Okay? So we should be practicing in conditions that are like the way we work, conditions that are easier, conditions that are harder. So here's a chest tube blindfolded. I like that. I got a video of us, the ultrasound guided IVs, you get the phantom gel, you can practice with a little gel kit. So I got mine on a shaker, I got them in the lab. So now I'm doing them with the rotor. So I got that, I gotta get that video in the slides that I haven't done yet. That's what I think we need to be doing. Before we take our intern to say, here's an 18 gauge needle, stick it in a vein please, of this patient who has done several IV drugs in their life. So, yeah. All right, well, who's onto this, right? Guess who's onto this? He's good at everything, including stealing my thunder. I filmed this like 3 years ago, micro skills of central lines. I have this video sitting on my computer. I'm like, oh yeah, I'm gonna bring Bellevue, like never before seen footage of Lingard, like doing these procedures, and then like over the weekend, like this weekend, he releases it as a podcast. It's like, thanks, jerk.
So Jeremy and I have been talking about breaking down the micro skills of central line placement. And this is a way to deliberately practice this technique in a way that you're not dealing with a patient, in a way that you can actually get skill mastery by breaking it down to each little piece and getting full expertise at that piece before you embrace the whole and do this on repetition. So we're going to talk about today is just a few of the micro skills that go into central line placement, and it's really extrapolatable to cell technique in general. So the first micro skill is learning syringe manipulation in the setting of being able to withdraw the plunger back. Because once you enter through the skin during a central line, you're supposed to be exerting constant negative pressure on the plunger. At the same time, you're able to move in and out, change your direction depending on what the ultrasound is showing you. And you have to be able to do that. So the finger motion is thumb on the plunger, and then I have my index finger and middle finger on the, I should say the index middle finger on the plunger and the thumb on the actual extrusion of the syringe itself. There's other ways to do this. This is the way I find to be easiest, but you need to practice and get really good at it. What's a fun way to try this with is actually you get like an orange or something and just pop it in there and just practice moving in and out while trying to exert negative pressure on the plunger. And this micro skill is you're at the point where you've already entered the skin and you've gotten your first flashback into your hub. Now what you need to do is you need to disconnect the syringe from the needle and put a wire in it. And this is the micro skill I think people fail at most. And so what you need to be able to do is stabilize the needle in such a way that there is no movement at all, both the needle tip in the vessel causing vascular trauma, or the hub that might push the needle in a little bit further, and now you won't be able to pass the wire or actually pull it out of the vessel itself. So very similar to the bridge you use when playing pool, you want it as maximally stable as possible. And when you look at a good pool player, they're always going to have as much of the hand in contact with the felt as possible, because that's going to give them the most stable bridge. And whether they have an open bridge or a closed bridge, you'll always see that their entire hypothenar eminence is touching the table, and that these three fingers are inevitably spread as far as possible to give you a beautiful tripod. And so open bridge, closed bridge, it's the same thing for placing the central line needle stabilization. So you get in there, you get your flash. What you want to do is, again, place your hypothenar eminence on the patient's body. That's the equivalent of the pool table felt. And what that's going to do is a few things. It's going to give you a stable base. Also, if the patient moves while you're trying to do this procedure, your hand is now a part of their body, and the hub of the needle will stay in its stable position even as the patient moves back and forth. So spread, hypothenar eminence touching the patient, beautiful stable base, thumb and index finger at the hub of the needle. So this is what I have done. Now, when you do this properly, what you should be able to do is, actually smack your hand, move the table, and the needle hub does not move. That's how you know you've gotten to the point where the micro skill is complete. Now, the next step is actually disengaging the syringe from the hub of the needle without moving it. That's the next skill. Now, you might say, oh, this is easy, and it is, but this is where a lot of the script happens. What happens is, inevitably, it gets pushed in just a little bit, or it gets pulled out just a little bit, and that's enough to dislodge the location of the needle tip. So you would have to be incredibly tight, holding it, ready, and now it's actually a twisting motion. And you should just practice time and time again, you know, a couple hundred, a couple thousand times, to the point where you can disengage the hub of a needle without causing any movement to the hub. And when you can do that, then you're ready to move on to the next microscope. For instance, if you lose this thing,
so cool.
well, now you're stuck with a J tip. And
you lose the
you
blue
do
tip,
the
right?
ridiculous manipulations where you try to turn it upside down, and you know, you can use the back portion of the wire. It's not as safe, but it's still not designed to protrude through the vessel. This is acceptable, and sometimes you have to do that. But the J-tip is safer because it's actually a rounded edge hitting the vessel. So what do you do in those circumstances? Well, you want to straighten the J-tip. And what you can do is if you hold the wire steady, you can actually advance the coil while leaving the wire stationary. So the movement is, you actually grip the wire portion at your hypophenar eminence with your pinky and ring finger, you know, digits 4 and 5, and you lock it to your hand. So now it's locked to my hand. Now with my thumb and index finger, I advance the coil. And so that's the
actually
movement.
hurts. I'll tell you, this
And
hurts.
now this is nice if you lose that blue thing. You know, you have your hub there, and you've lost your blue thing. Well, oh, no problem. I got a straight, you know, wire right there that now I can advance.
But after
All right, so that's micro skills on central line placement.
So when I did that a bunch at home, this one, and it hurts at first, right? I mean, like the first few days, I was just like getting like a guitarist, like getting calluses. But actually, you get really good at this, and it's very helpful. It just helps you with manipulation in general. So that's a new podcast that Lingard's got out. No thanks, Sammy, for stealing my thunder. So then really the question is like, okay, but is there any evidence that doing this will actually help us? And the answer is actually yes. Just in medical education in general, we know that these kinds of techniques will work if we do them. So here's actually the concept of really spaced repetition, right? So this is a paper called Improving the Impact of Didactic Resident Training with Spaced Education. And basically what they did was this. They took a bunch of students and residents, and they had them take a pretest. They all did about the same. And then they basically put them in 2 groups. The spaced repetition group, study for 2 weeks with practice questions. If you get them wrong, we'll give them to them again. And the other group said just study for the frickin' exam, which is least. And then a few weeks later, they take the test again. And the ones who did spaced repetition perform better, significantly, if I'm not showing the error bars. And with respect to the questions that related to the content that they were actually studying, and even a little better on questions that weren't matched to the exact topic. So the idea of spaced repetition, doing things over and over and over again, actually leads to better test scores. And on boards, 5 points is actually something. So, and it's an absolutely like gargantuan review of learning techniques that you should just read it. It's a great paper. But here's what works: spaced repetition, practice tests. We know that practice tests actually work. Note taking, that does not work. Highlighting definitely does not work. But spaced repetition and practice tests work. And mnemonics actually fail in a lot of studies. Mnemonics kick the crap out of not mnemonics on day 1. Like, it's unbelievable. It's like, boom, boom. But when they go back 6 weeks later, it's actually not even, the mnemonic group is worse. And the reason is that once they forget the mnemonic, they have nothing to fall back on. They don't have actual knowledge. So the mnemonic, okay, so I actually love mnemonics if you listen to the podcast. And so the mnemonics that I use have to be really, really relevant to what I'm doing. So the mnemonic that I think probably saved my life when I was training with Lingard, before he went upstate or whatever, was central lines. And I was like, oh God, which order, what do you do things in? And like, what happens next? And it's just, now we can do lines. Now we can do lines. Needle, wire, cut, dilate, line. And once I just had that in my head, like now we can do lines, like I didn't have to get, oh, what's next, what's going on. So that really helped my flow, and that combined with micro skills makes me look a little better at central lines. So I think that mnemonics can help, but the evidence on that's mixed. So now let's go to part 3, music in practice. And as I mentioned at the top of the talk, I don't recommend trying to give your opiate seekers music as therapy because they will kill you. But there are some things we can do. Music has been described as having some helpful properties.
I had a long talk with a lady in musical therapy, Johnny. She says that Mozart's the boy for you, the boy that sweeps the cobwebs away. What the lady said. You know, it's wonderful how they have it all taken out, John. They have music for dipsomaniacs, music for melancholy acts, music for hypochondriacs. What would happen if somebody got their files mixed up?
Oh, medication error.
I brought a lot of other music and see what you like. It shuts off automatically.
He looks so thrilled. Okay, so so maybe music doesn't work for everything. So let's talk about first what does not work. So for one thing, singing certain songs during CPR probably does not work. So the whole staying alive thing probably does not actually work out in practice. Here's the paper. The use of popular audio in CPR. That's the Tupac trial. I just want to point out. The best medical acronym in history. Does music improve compliance with recommended chest compression rates? The answer is probably not in people who are actually knowing what they're doing. For novices, maybe. How about the effect of listening to Nelly the Elephant during CPR? It's a crossover trial. They had Nelly the Elephant versus That's the Way I Like It by Casey and the Sunshine Band, which is the wrong tempo for CPR. I just want to point that out. And no music. And what they found there was that the Nelly the Elephant helps with the rate of compressions being correct. But unfortunately, the depth and quality of compressions went down. So maybe, we're chasing our tail here, okay? But there are some things where it might work. And before I talk about music as analgesia, I just want to briefly say, kind of give a conceptual framework for why this might actually have some relevance. And the idea is, from the 60s, this idea of the gated control theory. And the idea is, I'm not going to go into these neurons because we're, neurology, please. But it's a very simple concept. It's whenever you're existing, like right now, anything that happens to you is in context, right? So if you're in feeling good, or you're feeling confident, or you feel like something's happening to you for a reason, you can deal with it. The pain of sprinting during your workout is like, you feel good, it's a good hurt, right? Whereas if someone forced you to do these things in a labor camp, this would be a bad pain. So our brain knows this, and so we can use distraction techniques, and we can set our patients up to have better experiences. So the woman on the left is giving birth, and afterwards she's going to feel like she accomplished something. And here's a study. 2/3 of women said childbirth was the most painful experience of my life. Oh, and by the way, nothing anyone told me really prepared me for that. I heard it was painful. So 2/3, most painful experience of my life. Over half of them said they enjoyed it. Okay, that's got to mean something. And the person on the right is being interrogated by super spy Jack Bauer, and if she survives, she'll be in therapy for the rest of her life. So how we experience pain is really a subjective phenomenon that we can kind of control in some way. So that's what's going on with the gated control theory, and we can use this. So how about music versus aromatherapy in the waiting room? I love this trial because aromatherapy ended up being the control because it didn't work, and music actually decreased anxiety in everyone in the ER. The NNT at about 30. Okay. So a couple of studies. Music as an aid for postoperative pain. This is a very recent paper. 72 randomized trials. Modest reduction in postoperative pain. Modest reduction. They use less analgesia. That's a very good thing. More satisfied. Okay, no difference in length of stay, but that's good. And the choice of music did not matter. People always ask, oh, what music do you play? And some studies it mattered, and this one did. So this is actually an earlier pediatric post-op study. Same idea. Less pain. Out of bed faster. That's good. And then here's another one, lack repairs, intervention with music. A modest but significant decrease in pain, no change in anxiety, but 100% would use again. That's from the Annals of Emergency Medicine, coming out 25 years ago. Okay, so I love foam. I love free open access medical education. So that means I love ketamine. So we give ketamine for procedural sedation. And the feared complication in the ED we see a lot is the submergence phenomenon, right? The blood-curdling scream of the patient who is in the K-hole and they're coming out and they're having a terrible dream, and you and them and the nurses and the other patients are thinking like they're in The Exorcist, and everyone's very unhappy. So there's a whole adage, as you enter the K-hole is how you exit, right? You heard that? So if you have a nice dream, you're gonna wake up having a nice dream. And so the intervention is music. And so people who got nothing, 8 out of 25 said, not acceptable, we'll never use ketamine again. Please don't give me that terrible, awful drug. And when they gave them music, basically everyone said either no opinion, very small, or very acceptable, and one person is hard to please. So it didn't change the number of dreams. The number of dreams was actually the same, but the dreams they had were much nicer and they were actually much more satisfying. Okay, so let's look at a little bit more literature, music for pain relief, Cochrane. So, okay, who likes a 1 to 10 pain scale? I'm not a huge fan, because everyone's a 10. So in the Cochrane, they found a significant decrease by 0.5 points, so 5 to 4.5. So maybe like Nikhil Moroni, you're not that impressed. But how about a 50% reduction in pain? That's a pretty good marker. I think that's good. And what the Cochrane review found was that you were 70% more likely with an NNT of 5 to have a 50% reduction in pain just from music. And in this study, you needed to be told what music. Apparently, death metal is not helping. So that's the Cochrane on that. And then how about ventilated patients during the ICU? Now, some places in this city do this. It's not Sinai, or I don't know if you guys do it, but there's music being played at fancy ICUs in the city. And intubated patients, fewer benzo requirements, less fentanyl, less propofol requirements, just from that. Interesting, vital signs, I like this one. Lower heart rate, hopefully they're not grading down. Respiratory rate goes down. And then interesting, again, don't do this in sepsis, I guess, right? Because the map goes down too. But I think the idea here is if you have a patient in the ICU who's tacking away at about 100, and you can get them down in the 90s just by some music, some intern's not going to like fluid overload them. So that's the idea. So show me the forest plots. I know. Okay, so left of the line says favors music for lowering heart rate by somewhere between 2 and 10 beats. Anxiety goes down. This is nursing scales and need for benzos. Respiratory rate. Okay, so there's not a mortality benefit. Let's just keep it in context. But it is kind of interesting because it led me to this. I discovered what I call the Newman plot. David Newman's one of my mentors at Sinai. And it's number needed to treat on the x-axis and cost on the y-axis. And so like aspirin for MI prevention, it's like modest, pretty low cost. A CT for lung cancer screening, very, very high number needed to treat for that, fairly expensive. TPA for strokes, Swami, your favorite topic? I don't know. Just forget it. So where's music? Music's down there. It's a low NNT, low cost. Now, that doesn't mean it's the miracle drug, because the z-axis is clinical benefit, right? So the clinical benefit's modest. So in a way, this makes me think, like, what's the treatment we want to see? Like, when you read a paper, that's really what you should be thinking. Is it affordable? Is it practical for most patients? And is it actually beneficial? So this is like where we want to live. This is where we want our treatments to be. So in a way, music, I think, gives us sort of an idea of what the gold standard for any treatment going down the pipeline should be. So, I'm going to wrap up, summary. We are performers. How we enter and how we interact is really important to patient satisfaction and making that alliance. And we make entrances every day at EM. That's our job. Listening is multifaceted. Great clinician doesn't necessarily mean great teacher, but a great teacher is actually probably more important than a great clinician. Spaced repetition and having high expectations, I think, will improve our practice. Training should be harder than real life at times, and music can be a valuable treatment adjunct. So that's pretty much it. As First Long says, residency is rehearsal. And that's it. Just want to thank Natl, May, McBody, Lingard, Steve Beck, Lauren, my podcast co-host, who taught me everything I know about medical education, and Brett Nelson, and then Sony and the Hitchcock State were very nice to let me use those scripts. So any questions, happy to take them, and thanks for having me.